This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Thank you all very much for coming. It's a great privilege for me to be here and speak with you about the topic of health and wellness among older adults, challenges and strategies. I feel fortunate to have spent the last 20 years of my professional career working in geriatric medicine, and probably the most helpful education that I've had, though, was in working with and caring for my mother for the last 5 years of her life. After the death of my father, she moved to live with us here in California, and I had the privilege of working with her over the last 5 years of her life before she died at age 90. And so that was a very meaningful experience for me in terms of providing care and understanding some of the issues that affect older individuals. So my goals tonight will be to focus really on two aspects of health care. One is what the different or unique characteristics are of older individuals that require our attention. And then a second portion will be directed at how we might approach and optimize the care for these changes that exist. What I'm starting with here is an image of a Renaissance painting that was painted by Titian, I believe is how his name is pronounced. And this is the title of this is The Three Ages of Man. And I think I like to show this picture because it's interesting. Even though it was a Renaissance painting, it in many ways reflects our current ideas about aging and the three stages of life. And you can see that the babies that are sort of in the middle ground, actually, but are prominently featured. They certainly catch your imagination and your attention. They seem to be playing. Some are sleeping, very content, certainly healthy looking in terms of their weight, and somewhat carefree and angelic. And I think that's a common, we have nothing but sort of good feelings about little babies, and that's good. That's important. But even more in the foreground is the young and vigorous, healthy young people. So these are young adults. Here, these are a young couple in prime of life. They sort of exude invulnerability and the sense that if disease were to affect them, they would be strong enough to aggressively fight and preserve their robust life, and they're sort of in the foreground. And then you can look, unfortunately, pretty much in the background, an image of aging, which is that of an older person, a woman in this case, alone, certainly diminutive compared to the other figures in the painting, and interestingly contemplating death. At least that's what I would say, with holding skulls and that sort of thing. So again, it's not a very positive view of the whole aging process and the ages of life that all of us will be engaged in. And I think it reflects very much current ideas about aging as well. One of the things that I find very interesting in geriatrics, and this gets back to the normalcy question to some extent, is that that has been much more difficult for us to define. So all of you who have had children or been around children are very well aware of the milestones of childhood. And when your child or someone that child that you know is not meeting the milestones of development, you worry about that. And we know that typically a child will roll over and then sit up and then start walking and then eventually start talking. And those are all very predictable in a time course about what human development really should be. For aging, it's not the same. So the progress and the deterioration and the decline that's inevitably part of aging prior to death is very variable and unpredictable, and so defining what's normal at any particular age is very difficult. And it largely depends on the individual and their premorbid condition or their conditions that they've experienced throughout life. So defining normalcy in aging and having an expectation of where we should be is certainly more challenging. No matter what our image or view of aging is, I think all of us will acknowledge that there are significant changes that occur with the passage of time, and that these changes will impact on our health and our well-being. This diagram that I'm showing here is meant to illustrate an important concept in geriatrics, which is the concept of homeostasis. If we think about biological systems, this is a feature of all biological systems, and that is that there's a comfort zone illustrated here by this yellow circle where we live happily. We're in concert with our environment, things are going well, we're okay, that works very nicely for us. And then there's another zone that surrounds that comfort zone that is an area where we can reestablish our homeostasis or our equilibrium with the environment if we're kicked out of our comfort zone, so to speak. So that if we're a triathlete, for instance, and we participate in some vigorous physical activity, our bodies are stressed dramatically, and we're clearly out of our comfort zone here, but with our body's abilities to regroup, we can easily recover the comfort zone. This can happen hiking the dish. This can happen when we're exposed to the rarefied oxygen at high altitude. So all of those things are part of what normal homeostatic mechanisms are in all living organisms. What happens with aging, and as time progresses, that the comfort zone stays about the same, but what happens is that the zone around the comfort zone becomes quite constrained, so that our ability to adapt to stresses in the environment becomes constrained or stenotic, and so therefore the notion homeostasis. And this is a very important concept with aging because all of our organ systems do undergo physiologic change with advancing age, and those physiologic changes make them less capable of reacting to stresses in the environment. And so this is an important concept, and a reason why older individuals are more susceptible to things like heat stroke, or the people tolerate much less well a sustained tachycardia. If their heart's beating very quickly for a sustained period of time, they don't tolerate that very well, and they can develop heart failure and other symptoms related to that. Now clearly, and this gets back to the normalcy business, clearly there's a training effect that's possible here. So that if there's not only a matter of time, but it's also a matter of how well we take care of ourselves. And if we take care of ourselves very well throughout the years, there's a better chance that we can maintain a broader zone around the comfort zone to maintain our homeostasis. And we're going to talk a little bit more about that in just a minute. But you can imagine that if this is normal physiology, this is going to be even further impacted by then the imposition of disease. So there will be illnesses that affect us as we age, and really at any age, but certainly we have a chance of accumulating illness as we continue to age. And so you can see that there will be effects on this with diseases as well as the normal physiology. This is an illustration of the influence of comorbidity on older individuals. And this is some important information about some of the most common illnesses. So some of the most common chronic illnesses or comorbid conditions that affect individuals as they age are diabetes, heart disease, hypertension, arthritis. The one I left off of here is that vision is another important problem that affects older aging individuals, and so problems with vision. I didn't mean to leave it off for any particular reason, just I thought there were too many bars to put up here. But what you see is that if you take any particular individual with a condition like diabetes, it turns out that very few people with the condition of diabetes have diabetes alone. They almost none of them, only fewer than 10% of people with diabetes have only diabetes. Most of them, or many more of them, have two conditions at least, so diabetes plus heart disease, for instance. Many will have three conditions, so over 50% of them will have three conditions. And you can see that there's a substantial number of people who also have more than 5 or more conditions up here. And so the principle of accumulating illness is also very important as we age. So it's not only just one condition that we have, but the multiplicity of conditions that we have that contribute. Again, if you think back to that previous illustration of the homeostenosis, the cumulative effect of all of those different chronic problems will also contribute substantially to our ability to maintain good health and optimize our life and well-being. So another important aspect of this accumulation of chronic illnesses is the effect on our function. Function is a very important concept in caring for older individuals. And this is a graph that illustrates activity limitations according to the number of conditions. People who have no chronic conditions, very few of those individuals will have any activity limitations. So they're able to do their usual activities without any particular difficulties. People with one chronic condition, say diabetes or hypertension, have a much greater increase compared to the none of that. And then you can see the stepwise progression so that people with 5 chronic conditions, very few of them have no activity limitations. So the cumulative effect of these chronic illnesses is important. First of all, it's common, and secondly, when they do accumulate, they will have meaningful and important effects on functional ability, which is going to be another important concept. Now, related, again, completely predictable, again, for this group, I'm sure, is that along with the increasing number of chronic conditions, so too will things like how many prescriptions you are offered goes up, and fairly dramatically. This is the annual prescriptions by number of chronic conditions, so that people who have no chronic conditions may have fewer than 5 annual prescriptions for, I don't know what that would be for. Well, they might have an acute condition, so they might, have a pneumonia or urinary tract infection or something, and so they'll get some prescriptions throughout the course of the year, but with no chronic conditions, they have relatively few. Contrast that with people with 5 chronic conditions. They have almost 50 annual prescriptions per year. That's huge. So the cumulative effect and interaction of these multiple medications also plays a role. And even though we think we know what we're doing with medications, and we do to some extent, where we get into trouble is when we have people on multiple different medications and not completely understanding the intricate interactions that each of those medications has. So now we're dealing with physiologic changes, we're dealing with the accumulation of chronic conditions, the interaction of those chronic conditions on function, and the interaction of those and the effect of those conditions on medications, which will then feed back and have further impact on function, on physiology, etc. So it gets to be kind of a vicious cycle, so to speak. So let's now turn from this baseline understanding of some of the factors that influence health and well-being in older age to some thoughts about the paradigms that we use in thinking about health care and how these might need to change when we're specifically addressing the needs and cares of older individuals. I borrowed this next slide from a colleague of mine at UCLA, David Solomon, who's one of the giants of geriatrics in America, and he's in his 80s, if not 90 now, and has been working in this field for a very long time and has contributed tremendously to the field. And he draws a distinction very nicely here between geriatrics and traditional medicine. So traditionally in medicine, what we think about is that there's some specific pathology. Something goes wrong at a cellular level, at a molecular level, at an organ system level. There's some kind of pathology that's happening. That then is manifest in its cumulative effects as a disease. So we recognize that somebody's got a particular disease or condition. And then that disease manifests itself to the physician as symptoms. So when a patient presents with particular symptoms, one of our jobs as physicians is to try to figure out what symptoms are important, and then putting those symptoms together, what disease is reflected in those symptoms. And so we are able to establish a disease, and then knowing something about the disease, having gone to medical school, we then can understand or impute what the specific pathology is, and by knowing the pathology, we can deliver the silver bullet to fix the pathology, therefore fix the disease, therefore eliminate the symptoms. Sounds good, doesn't it? Perfect. And so that's really the goal of traditional medicine. That's what we've been doing all these years. So when somebody gets pneumonia, manifest by cough and sputum and fever, we're able to make the diagnosis, we're able to presume what the pathology is, treat specifically with appropriate antibiotics, and take care of that. And that's really our model. And what we teach to a large extent in medical school these days is this model and the curative nature of what disease is all about. So our goal really is to cure disease and to eliminate symptoms and to eliminate the pathology. Things are a little bit different as people get older and dealing with geriatrics. So the new model with geriatrics is that certainly there are pathologies, for sure. Some of those pathologies are singular. Sometimes it's multiple pathologies. Sometimes there are multiple disorders that are going on, or an interaction between a pathology and the normal physiology. So that's certainly we're not eliminating that. That's still very important, and it's listed here first in this column. There's also the aging process. This gets back to what I was telling you about at the very beginning, the homeostasis. So the fact that with advancing age, physiologic responsiveness and physiologic ability to recover is impaired. And so the aging process has an important impact that interfaces and interacts with the multiple pathologies. So that's going to be very important. Now, what's very nice about this is that that's not all. There are also other very, very important factors. Socioeconomic, it's listed here as handicaps, but socioeconomic conditions is really the way I would phrase it. So anything that affects one's socioeconomic status is going to have potentially very important impact on health and wellness, and we'll look at that in just a minute. And so too unsuitable environments. So people who are not in the kind of supportive and nurturing environment that may be appropriate will have more difficulties than those who are not. So we've multiplied or increased fairly dramatically from just simple specific pathology to multiple levels that need to be considered. Those conditions work together to form an interacting network of disorders. Those disorders are often presented with symptoms, disabilities, or handicaps, and sometimes these are referred to as some of the geriatric syndromes that you're going to be hearing about both tonight and in subsequent talks. So things like falls. You know, when you're a young person, when you're a baby and you're just learning to walk and you fall, that's pretty straightforward, and there usually aren't any consequences to that. You get up and you toddle along again. But a fall in an older person can be very important. It can cause very significant pathology, significant impairment in functional status, and even has a high risk of mortality. So falls is an example of how all these kinds of different interacting processes develop into a network of disorders that causes a significant disability or handicap. Other examples include urinary incontinence, which again can be multifactorial, has lots of different impacts on people in terms of their symptoms and disabilities and handicaps, and so the treatment needs to fold back and to address all of these issues, not just the underlying pathology. And then persistent pain is another example of this. So people who have a pain syndrome may have multiple different interacting reasons for that need to be thought about and addressed. So I've already, in the first part, talked a little bit about the fact that there are multiple pathologies and the accumulation of chronic illness. And I've already spent a little bit of time introducing you to one concept of the aging process, the concept of homeostasis. But I'd like now to turn some attention to the socioeconomic and the environmental business, because I think that's very important and sometimes under-recognized in the way we think about health and wellness. So what I'm going to do first is show you some information from the Nurses' Health Study on a very important topic of heart disease. So if you're looking at heart disease and you're looking at factors that influence heart disease and what we can do to reduce the risk of heart disease, this was a very important study that looked at that. It was published in the New England Journal in 2000, so it's not hot off the presses, but it's nevertheless very important. And what this shows, this illustrates the risk of heart problems according to modifiable risk factors. The study altogether, 84,000 women, 1,100 of them developed heart disease, only 5 in this small group, which only represented 3% of the population, and they had 5 low-risk factors. Well, what do you think those low-risk factors are? What factors do you think would protect a woman from developing heart disease? Diet. So a good diet, and they had parameters for what a good diet was, but you can imagine what a good diet is. Don't look at the nutrition pyramid because that's kind of old school now. But your mother knows what a good diet is, so you can ask your mother about a good diet. So non-smoking, huge. So non-smoking was another important factor. Moderate to vigorous exercise, 30 minutes a day, huge, very important in reducing the risk of heart disease. Maintaining a normal body weight. So a body mass index is the way we refer to it now, of 25 or less. And guess what else? Regular consumption of alcohol. In moderation. In moderation, I will stress. But regular consumption of alcohol in moderation. Those were the 5 risk factors that were characteristic of this low-risk group, which only represented 3% of the total population. But in that group, only 5 of those women had heart disease out of the 1,100 that ended up having heart disease. And the other important factor is that if you take those 5 risk factors, the attributable risk, population attributable risk was 82. So what that means is that 82% of coronary events or heart problems in this study group could be attributed to not adhering to those 5 low-risk factors. 82%. That's huge. I mean, this is way bigger than anything that we can do as treating physicians. So we're very proud about giving you a cholesterol-lowering medicine. Ooh, that we can really do, and we can follow it, and it's very cool. But the attributable risk with that is trivial compared to this. 10 or 20%. 82% you can avoid your heart attacks by a good diet, keeping your body weight at the right amount, not smoking, exercising regularly, and consuming some alcohol. So those are all very important risk factors to be mindful of. And this gets back again to this notion that was addressed in one of the questions that we talked about earlier on, and that is issues about prevention. What can we do to prevent? So if you're talking about preventing, these are the factors that we need to be thinking about, that all of us need to be thinking about. So it's never too late to start, but these are going to be important factors to think about. So just quickly, the 4 risk factor group eliminated alcohol. So even if you don't like alcohol and you're in this next most favorable risk category, still the attributable risk, if you avoided, that 64% of the heart attacks were due to people who didn't follow those 4 risk factors, so that's all the ones we talked about minus alcohol. And if you eliminated both alcohol and you didn't maintain a good body weight, you were in this category, and still you can eliminate 50% of the risk of heart attack over time by following the other 3 favorable risk factors. All right. So one of the important things about this is that, some of these risk factors that we're talking about here are not necessarily under the purview or in the purview of physicians, right? I mean, we don't go home with you and make sure that you're eating properly or that you're exercising daily. And so this calls for the need for some involvement of factors and influences outside of traditional doctor's offices and that sort of thing. And here's another example of that. This was a paper that was just presented at the American Geriatric Society meeting this past week in Chicago. And this was a study that looked at collaborative care, or managing complexity in patients with dementing illness. This was a study that was done in Indianapolis, and they looked at, they went into doctors' offices and identified patients who had dementia, and then they randomized those patients to either usual care, so they let the regular physician provide whatever care they thought, or a comprehensive collaborative care system that involved a nurse and other providers to ensure certain aspects of care. So the things that they did in this experimental group was that, first of all, they were very careful to establish a specific diagnosis. So you've seen that before. We talked about specific pathology and the need for establishing a specific diagnosis. That's going to be very important. They also emphasized the use of community resources. So again, thinking it's not only what's happening in the doctor's office, but we need to involve community resources as well to help these patients and their family and their caregivers. Consider drug therapy. So for sure there are treatments that are available for these conditions, and so considering drug therapy was important. Addressing behavioral problems. largely non-pharmacologically, but sometimes needing pharmacologic interventions. Treat comorbidity. Remember, we talked about comorbidity, all these accumulating illnesses. So if you get those under maximum control, that might be of some assistance. And support the caregivers as best you can. These are the people that are doing all the work. Support the caregivers as best you can. So what happened when they did this and they followed these patients over time? Well, they found there was some really good news, and that was that the people who were in the experimental group who had that collaborative care, the patients did experience fewer behavioral symptoms, behavioral problems, and this was statistically significant and clinically important. So people did better from their behavior perspective. Patients with dementia did better in this collaborative care. And very importantly as well, caregivers reported much less stress. So this was very helpful for the caregivers, which is, again, extremely important. So the other side, though, is not everything got better, and it's very interesting to note that despite the vigorous efforts, in the end, the two groups, there was no change in cognitive function. So there was no difference between the usual care group versus this more elaborate group in terms of the patient's cognitive function. So we're not having much of an impact on that. Also, there was not much in the way of changing physical functioning of the patients. Despite the best efforts, we were not able to, this group was not able to improve the functional status of patients. Also, there was no change in nursing home placement. So those that continued to deteriorate and require nursing home placement were about the same in the two groups. And also, very importantly, we didn't change death. So the mortality rate in the two groups was equal. To me, this is very important because it helps us define what appropriate goals of care are. If what we're really trying to do here in our managing our patients is to affect mortality or affect their nursing home placement, that could be very difficult to do. That may not be a realistic goal because the conditions and the cumulative effects of these various conditions may not be what we can really meaningfully achieve. But on the other hand, that doesn't mean we can't do something, and we can make the patients have many fewer behavioral problems, which is going to be important for their interactions in the community and with life. And we're also going to make a very important impact on caregivers. So I think this is the kind of information that we know about in geriatric medicine, that defining appropriate goals is going to be different. This is different from pneumonia. Remember pneumonia, we treated you with a specific antibiotic and you were cured. That's traditional medicine, and that can be very effective. And that can also affect older individuals, no question about it. But some of the more complex issues may be more difficult to affect. And so I think understanding what we're dealing with in terms of realistic goals for treatment is going to be very important. My second to last slide here is an illustration which I've labeled Back to the Future. This is a diagram that I've borrowed actually from one of my colleagues and collaborators, Kelly Skeff, who's involved with teaching us about clinical teaching. And what we've done is adapted some of what he's done in terms of illustrating the interactions between the physician, the patient, and the condition. And what you're seeing here is, and I purposely put the patient on the top and sort of in the center, and there's an interaction between the patient and the disease or condition that they have. There's also an interaction that's happening between the patient and the physician, and of course there's always been an important interaction between the physician and the condition. Now you can imagine that what's focused on most in medical school, I don't think I'm telling any stories out of school here, is this, right? This is what we focus all of our attention on. How does the physician deal with the condition? How do we treat congestive heart failure? How do we treat diabetes? How do we treat, et cetera, et cetera? And so too often the patient is kind of left out of that paradigm. And what I'd like to see happening more and more in our care of geriatric and older individuals is to emphasize that all of these interactions are going to be important. We need to work with the patient to help them understand and cope with their condition and prevent their condition as much as possible. This is going to be very important. The patient and their own personal condition is going to be extremely important. This axis is very useful for us to know about and to try to help by looking down and interfacing on that axis how to make that work better. This is an extraordinarily important axis and one that is incredibly rewarding, at least for me, and that is the interaction, the personal interaction with the patient about the condition. But having a personal relationship with this patient, working with them, giving them guidance and advice about how to cope with the condition that they have. And of course, I mean, I'm not stepping away from our primary or an important role that I learned about in medical school is being up to date and very knowledgeable and skilled at dealing with whatever condition they have. But I think that it's important to be mindful of these complex interactions, and also to realize that this is in a context. This is not in isolation, but there's a context that happens which includes the caregivers, it includes the environment, and it includes all kinds of other factors that are equally important and that inform us and help us in our optimizing the patient and the care that patients obtain. So my very last slide before I stop and allow you to throw tomatoes or ask questions or whatever you want to do, is just to give you, and I had a hard time figuring out what to share with you, and I'm not sure that these are necessarily the best, but these are two websites that I think you might find interesting if you're particularly looking at individual conditions and resources in a particular area in the web. The Health and Age website is one that's supported by the American Geriatrics Foundation, which is separate from the American Geriatric Society, but is a website that has lots of useful information about particular conditions, about particular interventions to address those conditions. And it's vetted by health professionals in geriatrics, so I think it's a reliable kind of resource for you. And then similarly, and again, I have no influence or no interface with Merck at all, the pharmaceutical company, but they too have a foundation, the Merck Foundation, and that Merck Foundation addresses issues with aging, and so the Merck Medicus website is another useful place for interesting information about healthcare issues involving the whole range of people, but including geriatrics patients as well. So, thank you for your time and attention. I'm going to stop here, and I look forward to trying to address any questions or rebuttals that you might have. Thank you. The question was, she was asking about the research that was done in Indianapolis about the comprehensive care provided to patients with dementing illness and how long the intervention lasted. A very important question, because obviously the impact of those interventions are going to be variable depending on how long it is. You wouldn't expect to see much change, for instance, in cognition if it's only a few months study. This was a year study. Even then, it may be that it wasn't long enough to see any meaningful impact. The question was, what about the costs associated with these? And with the outcomes the way they are, will they be funded and will they be supported? And what I can say there is that we got another very interesting dose of reality from representatives of CMS, the group in Washington that controls Medicare and Medicaid. And they spoke very specifically about the changing attitude about health insurance through Medicare and Medicaid towards the kinds of outcomes that they're talking about here, which is behavioral kinds of issues and caregiver stress, and focusing on those and not worrying so much about some of the other outcomes that have less meaningful, may be less meaningful to patients and caregivers. So again, the question is an excellent one. I can only be cautiously optimistic that maybe somebody will pay attention to these kinds of outcomes. The question is defining alcohol in moderation and then talking about different kinds of alcohol. This is a very hotly debated topic, but I think most folks would now agree that we're talking about 1 drink per day, and the type of alcohol is probably not as important as some people have said it was. I mean, there has been talk about red wine being particularly good, but I think it's not as clear as it used to be thought to be, and it may just be alcohol of any kind. 5 grams is the specifics in this particular study, but that is equivalent to about a drink per day. So let me repeat that question. So she was interested in what I was talking about with respect to behavior problems. So in people with dementing illness can have a variety of different behavioral manifestations. Sometimes they become particularly paranoid. Sometimes they wander or have compulsive behaviors. Sometimes they're very aggressive and agitated in dealing with other individuals. And all of those are kind of behavioral manifestations of dementing, or can be behavioral manifestations of dementing illness that can be, then they can be handled often behaviorally without the need for any kind of drug interventions. That's a wonderful question, and you're you're not asking the right person for that one. Although I do have to say that my background is in general medicine, and I do continue to work in general medicine. That's a tough question. I think the best answer I can give is find a good doctor, whoever that happens to be. If you're happy with your general practitioner, I don't have any reason to believe that they're going to be more difficult. And in fact, the study that I showed you with that was done in Indiana involved only general practitioners, not specialists. And unfortunately, we're not going to train sufficient numbers of geriatricians anyway. So, coffee. Well, I like coffee. The question is, what do I think of coffee? I like coffee, and I don't know about any data about whether it's good, bad, or indifferent. So the question is, what's the mechanism by which alcohol protects health and well-being and prevents heart disease? Again, an area of active investigation. It probably has something to do with the effect on coagulation, though. It probably has something to do with the blood flow that's affected by various coagulants in the blood in terms of that. And once you get above that, not only does that effect not pertain, but also the adverse effects of alcohol, which are very important on liver and other organ systems, come into play. The question is, how do we work to helping a person interact with their condition? Well, this gets back to basically sharing information about what these conditions are and what's realistic and what's possible given the particular conditions that you have. And it gets, again, to some of the appropriate goals of care. So if you've got a condition where the goals of care, you may want to live forever. I mean, some people want to live forever. That's sort of an unrealistic goal of care. It's just not possible. And so being clear about what this disease is about, what its natural history is, what our ability to affect that disease will be, is extremely important in decision making. Well, let me give you one quick example, and that is, for instance, with arthritis and the troubles with joint problems as people age, there's often the question about whether or not I should have a joint replacement. I love joint replacements, and they can be very helpful, but there's a price that some people have to pay for that. There are effects, there are adverse effects of that need to be thought about and realized, so that the person saying, yeah, I'd like to walk better, I'd like my pain to be gone, and this is one option, but it's not a guarantee, and you have to be mindful of what other conditions or what other options there might be to make an informed decision. I was taught when I was in medical school in the last millennium that one of the most merciful things about dementia was this phenomenon of anosognosia, or not knowing that you were losing faculties. That may or may not be true, and especially early phases, many people are aware of it, and it can be quite painful. I generally would recommend taking a very forthright and straightforward, but also understanding that the ability of the person to really understand and comprehend what you're talking about may be very limited. So I wouldn't perseverate about it. I mean, I think it should be brought up, but I wouldn't continue to reinforce and to try to have them, you know, finally understand that there's a problem. I don't think that's particularly helpful.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.